Now coming to another important problem with the cardiac surgery, that is renal insufficiency. Perioperative renal failure that necessitates dialysis occurs in 2% of the patient undergoing cardiac surgery. The definition of renal insufficiency or failure varies among various studies, but 3 useful criteria include your serum creatinine level greater than 44 millimole per deciliter or greater than 0.5 milligram per deciliter higher than its preoperative value. That means if the preoperative value is 1.3, in the postoperative period it should be greater than 0.5, that is 1.9 milligram per deciliter. Second criteria is the serum creatinine level more than 50% greater than the preoperative value. For example, it is 0.9 milligram per deciliter. It is 1.8 milligram per deciliter in the postoperative period. And the third criteria is the serum creatinine level greater than 2 milligram per deciliter. These are 3 useful criteria to say that patient has some form of renal insufficiency. Now coming to what is called the rifle classification for acute renal failure. Each of the word in the rifle has an abbreviation. R is for risk. Here the plasma creatinine value is increased 1.5 times or the GFR, glomerular filtration rate, decreases by greater than 25%. In the urine output criteria, it is less than 0.5 ml per kilogram per hour for at least 6 hours. Coming to injury, I stands for injury. Here your plasma creatinine level is increased 2 times and your glomerular filtration rate decrease is greater than 50%. Here the urine output is less than 0.5 ml per kilogram per hour for 12 hours. That is important. Coming to failure, the plasma creatinine is increased 3 times. Acute plasma creatinine rise of greater than 350 micromole per liter or an acute rise of greater than 44 micromole per liter. Here the urine output is 0.3 ml per kilogram per hour for 24 hours or the patient is anuric. There is no urine output for 12 hours. Coming to loss, this is persistent acute renal failure. There is complete loss of kidney function for greater than 4 weeks and ESRD. E stands for end stage kidney disease which lasts for more than 3 months. This is the rifle criteria for acute renal failure. Coming to the risk factor for renal insufficiency. Patient having pre-existing renal insufficiency, type 1 diabetes mellitus, elderly patients age greater than 65 years, major vascular surgery where your renal artery blood flow is compromised, arteriopathy, genetic predisposition for renal failure, recent exposure to nephrotoxic agents. This includes radiocontrast dye, bile pigments, aminoglycoside antibiotics and non-steroidal anti-inflammatory drugs. Increase serum uric acid level. These are all pre-operative risk factors. What are the intraoperative risk factors? Emergency surgery, repeat cardiac surgery and redo valve surgery, your cardiopulmonary bypass exceeding more than 3 hours, hypotension resulting from hypovolemia, low cardiac output syndrome or embolic phenomenon, hypoxia. This hypoxia affects particularly the nephrons in the medullary region leading to acute tubular necrosis. Coming to the clinical impact of patient having renal insufficiency. Post-operative renal insufficiency is associated with longer ICU stay, hospital stay and more importantly, it increases the mortality. Mechanism of renal injury after cardiopulmonary bypass is very similar to administration of radiocontrast dyes. Adequate hydration, maintaining normovolemia and avoidance of the nephrotoxic agents are the 3 best possible way to avoid renal dysfunction in cardiac surgical patient. So management includes maintain your cardiac output, maintain the perfusion pressure so the renal artery gets adequate blood flow and maintain the intravascular volume. Discontinue all the nephrotoxic agent, that is NSAID and certain antibiotic. Diuretics are not helpful and may be harmful. You have to understand that. Unproven pharmacological therapies including mannitol, calcium channel blockers, angiotensin converting enzyme inhibitor, dopamine infusion, atrial natriuretic peptide, N-acetylcysteine have not proved as a renoprotective agent. Continuous dialysis can be better than intermittent dialysis.